Hi everyone, I want to talk to you about aspiration pneumonia. Let's go. We have all aspirated at a point in life, but we have not all come down with aspiration pneumonia. Why? Let's find out. We all aspirate often, but that gets cleared off. To stay healthy after aspiration, in other words, not to come down with aspiration pneumonia, we all need the following. Good defense mechanism. That means your immunity is strong and all other stuff that could pass out or push out your aspirate are there. Epiglottis to be closing appropriately so that less stuff will go down into the trachea and the lungs. Good cough reflex. When that is down or not there or impaired, then we won't be able to cough whatever we have aspirated out. Non-toxic aspirates, because it's not everything that is aspirated that could cause trouble, but when it is toxic, uh, there is a separate presentation on aspiration pneumonitis. I think you should check that out. Then we need no obstruction from the particles of fluid that we've aspirated, and it should not be frequent, and it should be in small amounts, because when we aspirate anything in large amount or more frequently, then infection will set in after and we have aspiration pneumonia. Aspiration of microbes from the mouth, that is oral cavity or nasopharynx, will lead to inflammatory process. Aspiration pneumonia from infectious process caused by inhalation of nasopharyngeal pathogens is very common. The lower respiratory tract is not so sterile as once believed, but know now that microbiome extends from the nasal passage to the alveoli. So in the past, the medicine was that the lower respiratory tract is so sterile, but that has been debunked now. The role of aspiration pneumonitis in aspiration pneumonia. Like I've said just a while ago, that you need to check out my presentation on aspiration pneumonitis separately. But here, I just want to link aspiration pneumonitis to aspiration pneumonia. Once medicine syndrome has occurred, I've explained everything about medicine syndrome when I was presenting the topic on aspiration pneumonitis. So you can check that out if you want to know more about Bendestein syndrome. So once medicine syndrome has occurred and aspiration pneumonitis has been diagnosed, it is possible that bacterial superinfection can occur. Hence, aspiration pneumonitis as the needles for aspiration pneumonia. But most times, the pathogens are aspirated directly into the lungs. What are the risk factors? Risk factors for aspiration pneumonia. Decreased dental or poor dental hygiene. I don't need to expatiate more on that, that's pretty straightforward. Decreased level of consciousness. An unconscious person cannot determine what he or she will want to do. So whatever happens, if cough reflex is still there or is not there and nobody is helping to sanction anything, that is why when we admit people, we check the airway, be breathing the circulation. It's not a joke, because when they go from being conscious to unconscious, anything along the airway could be aspirated and leads to some of these problems. Anesthesia. When anybody is under anesthesia, particularly general anesthesia, the cough reflex could be cut off Now, you are just there, everything is down, but the good people, the anesthesiologists, the doctors, and the nurses in that unit will help you out. Everything is in place. That's why you're intubated. Dysphagia. Sometimes when people couldn't swallow, when they have swallowed difficulty, they aspirate the content because there's backflow. And when epiglottis opens up when it's not expected, then there's possibility of aspiration and choking. Prolonged vomiting, wrenching all the time, part of it will not come out straight. When the epiglottis is open a little bit, part of it goes to the lung. Recumbent positioning, that's why some patients that have particular problem are advised to be placed at angle 45 degrees and so on and so forth. That's a gas tube feeding. Not everything will go straight into the gastric system or esophagus, but sometimes even while passing the NG tube, it could inadvertently end up in the lungs. And if appropriate precaution is not taken or is properly checked, the individual could come down with aspiration pneumonitis or aspiration pneumonia. Trigger intubation for the same purpose. Bronchoscopy, endoscopy, gastroesophageal reflux disease, alcohol, illicit drug, seizure disorder, stroke, and old age all could enhance the possibility of aspiration, leading to aspiration pneumonia. How do we prevent aspiration pneumonia? Now that we have known most of the causes, then we can go over all those risk factors one by one and find out which one is applicable to us or to our grandfather or to our uncle or grandmother and help out. Like we said, dental hygiene, then keep it clean. Dietary changes, maybe small fluid, for particularly those who have gastroesophageal reflux disease or those who have dysphagia. You discuss with your doctor on how to arrive at the best way to feed. Proper positioning at elevation of 45 degrees because we talk about recumbent positioning, and subglottic drainage when there's anything blocking the airway in any form, we got to drain it out. And the contamination of the digestive tract using chlorhexidine, non-absorbable antibiotics applied to the oropharynx, and some will use glucocorticoids like hydrocortisone. The reason is that when the content of the stomach is aspirated, then we are likely going to get some of these headaches. What are the culprits? Anaerobes, gram-negative, gram-positive, or bacteria. If acid has been aspirated with Staphylococcus aureus or gram-negative bacilli, the rise in temperature will be faster. That will be a clue. In case anaerobes are the pathogens aspirated along with gastric content into the lungs, the story might be a bit different. Why? Instead of very fast rise in temperature, like I've just said, in case of Staphylococcus aureus or gram-negative bacilli, but I'm going to have mild or slowly progressing symptoms. There'll be no rigors. When the sputum is cultured, it's likely going to be negative, but the sputum will be putrid, nodal, and there could be lung abscess or empyema. Bronchoscopy with alveolar lavage for Microscopic culture and sensitivity will give anaerobes in large numbers. Treatment here, well, I have chosen tazocine intravenously, clavulin per and metronidazole with or without amoxicillin, or if it's an individual with penicillin sensitivity not allergic, then you can give penicillin G. If penicillin allergic, but not allergic to cephalosporin, because most times there's cross allergy between penicillin and cephalosporins. If the individual could still take cephalosporin, why not go for ceftriaxone or carbotazine, and you might combine that with metronidazole. The reason why we are choosing metronidazole is that you are dealing with likelihood of anaerobes being aspirated as well. And clavulin is covering a broad level of organism. The same thing, tazocine is covering pseudomonas and the rest like that. If the individual can't take cephalosporins, then use clindamycin. But when you are using clindamycin, you are at risk of pseudomembranous colitis. In that case, combine your metronidazole with clindamycin, because metronidazole will handle pseudomembranous colitis. If lipoid pneumonia, in other words, if it's mineral oil that is being aspirated, just treat appropriately. If it's mechanical obstruction with particulate matter causing the aspiration pneumonia, if that particulate matter is secondary to water, saline, or barium ingestion, do one thing: treat with atropine. When you treat with atropine, that will be enough. If solid particulate like peanuts, teeth, or tiny toys, remember that peanuts and vegetables will not appear on the chest x-ray. You may not see them there. So be careful. Don't jump to that conclusion that no, okay, that is not possible. So just know that. If at the larynx or trachea, it can lead to respiratory distress, cyanosis, and aphonia. Immediate death is imminent if no appropriate intervention is embarked upon immediately. Aspiration of meat at a restaurant requires Hermes maneuver, or else there could be deaths very soon. You can treat this type of cases with rigid bronchoscopy or fibriotic for the removal of the foreign objects. In conclusion, for now, knowing your risk factors will afford you the opportunity to prevent what is preventable, and aspiration pneumonia is preventable. Just like I've said, that consider these risk factors in my grandfather, grandmother, my uncle, my aunties, and everyone, and even myself. Then work against those risk factors. If you're able to do that, it's very likely that you're going to prevent aspiration pneumonia in that individual. With timely intervention, pneumonia mortality should continue to drop. Thanks for listening to my presentation. Kindly remember to subscribe so that you can be getting these publications immediately they're published. Thanks.